Dr. Foa, we are now live. And so we're having you and I are having problems with the sound. So we are on our phone with each other and and here with each other at the same time. And we made it happen, didn't we? It's wonderful. And you look lovely.
Thank you. You do too.
All right. So, everybody, we're so happy that you are here with us. As always, in the comments, please send your love and support. We're so honored to have Dr. Foa spending your precious time here with me. For those of you who don't know me, my name is Ricky. I am a psychologist, act trainer, and I host these events, Cocktails and Courageous Conversations. Cocktails are optional. Courage is guaranteed. And basically, it means that I get together with people that I love and admire, and we have a cocktail and we have a kind of informal chat. And I'm just honored that you are willing to be here with me, Edna. Um,
It's my honor.
you,
Thank you very much for inviting me.
yeah, it's always a pleasure hanging out with you. And so I wanted to tell people about some of the things that you're doing because like if I were going to introduce everything that you are have done and contributed with in this world, I think we would spend the entire hour on that. So just wanted to highlight a few of these. And you can of course also introduce yourself, but Dr. Four, you developed the prolonged exposure method, and I just wanted to give people a flair of what we're talking about here. So let's check out. You have got so many awards. Here is one, the Distinguished Scientific Contributions to Clinical Psychology Award from the American Psychological Association. Yes, the Lifetime Achievement Award presented by the International Society for Traumatic Stress Studies. You've had the Lifetime Achievement Award presented by the Association for Behavioral and Cognitive Therapies. You have the 2010 Lifetime Achievement in the Field of Trauma Psychology Award from the American Psychological Association. You have the inaugural International Obsessive-compulsive Disorder Foundation Outstanding Career Achievement Award. And
Maybe that's enough.
no, I just wanted no, that there's two more I want to say. 2 weeks, just two, no, actually 1 month ago, on November 16th, I know that you had the Academy of Cognitive and Behavioral Therapies 2021 Lifetime Achievement Award, and the New York Times uh, nominated you or awarded you as one of the top 100 most influential people in the world. That
Thank
is
you.
pretty amazing. And here you are with us. Yes. And so, Dr. Foa, the world knows you as this woman who has all of these awards and has developed prolonged exposure, which we will talk more about shortly. To me, now you know this, but I just wanted to say, apart from all of what you have contributed with as a professor and all of your academic, you are also a dear friend of mine. And we've known each other, I don't even know how long, but we have known each other for many, many years. And I've been to, I think, your workshop 10 times, and I think I was literally crying on your shoulder when I got divorced. Like the day I was telling my children, I was like on your shoulder crying. And so it's just
In
an,
a wonderful restaurant.
and in a wonderful restaurant. And so one of the things that I'm hoping that we will also see in this hour that we have together and that I'm inviting people to see is that apart from being an outstanding, apart from all of your outstanding academic achievements, you are also a very wonderful person that I hold so close in my heart. I know your family, you know my family, and just loving the way that the kids, when we talk, I'm in the car and the kids are going, "Hey, Edna," it's just amazing. I really admire you. And for many reasons. I want to give you a chance to talk about your work. I just wanted to let people know how much I admire you and how much I look up to you, because you are one of the
Yeah.
strongest and fiercest females that I know.
Yeah, and I'm glad you mentioned our friendship, other than just the professional relationship.
Yes, we've been together for a long time, and it's pretty amazing to for me, it's pretty amazing to have a woman that I can look up to and that I can talk to and that I can learn from both at work, but also in my personal life. And you are like that to me. And I really appreciate the talks that you and I are having outside of work. So, would you mind?
And the good food.
And the good food. And the good food. And sometimes we actually do share a glass of wine together when we are in the same
That's
place, don't
right.
we? Yes.
Now,
So, so would you mind telling the people who are watching this a little bit about yourself?
well, I actually started my career relatively late. I never imagined that I would become an important figure in my field. Neither did I really want it or aspire to it. I, my first child was born when I was 24 years old, before I finished my undergraduate school, and the second one was born when I, in the middle of my PhD. And the third one was born in the beginning, really, of my career, because until then, I was a mom. I did work full time, and I was mostly clinician and a cognitive behavioral therapist. But once the third one was born, I said, well, maybe it's time to do some more interesting work, like doing research and teaching and training and writing papers and contributing uh, a knowledge that may be helpful to the field. And that was really when my husband at the time actually was also a mentor of mine. And when he said to me, why don't you do a PhD? I said, I don't need a PhD. I really need just a master's degree because I never use a PhD. I just want to be a clinician. And he said, you know what, you may change your mind. And it's not that difficult to do a PhD. Then why don't you do it anyway? And I said, okay. And that's how it happened. So all my career really happened by chance. Just because I became interested in research, I like to write. I like to write papers, books, and and then things just happen.
Things just
So
happen.
when the young generation, especially women, are asking me, what to do in order to become, kind of famous, I don't know, but as somebody who contribute and somebody who is considered to be prominent in an area, I said I don't know because I didn't choose it. And I didn't work, I didn't aspire it. And I didn't do all the things that you're supposed to do. From the beginning of my career. I already started, I was maybe, 37 years old. And which, the young people now, are actually plan their careers more, especially the women. It's the men. the men have planned their career, had planned even during my time, during when early time, but not the women mostly.
And so
So
I
that's
hear you
kind of.
say that it happened. And also, can I just add that I know that you work so hard and you're still working so hard. What is that like for
It's
you?
true.
Yeah. I know that. So you're not, let's not go into the details of age, but I do know your age and and we talk about this and you're
No, you
so
don't.
I won't tell
Everybody
anybody.
knows. You just go on Google and you find my name and you know my age.
Exactly. And so you're still working so hard. What is that like for you? Do you ever like so let me ask you this. Do you ever not work?
What do you mean by not work?
So I know that you love to travel, and I know that you have a lot of friends both where you are and in Israel, right?
Yeah,
Yeah. Could you tell us like
yeah. I
what
just
is it?
came from Israel. I was like 2.5 months there.
Yeah, I
But
know.
there too, I was working because now with the Zoom, you
Yeah,
can be anywhere in the world and just work.
that's amazing. What do you like to
Hmm.
do when you're not working?
Oh, I like to collect art and antiques. Um, and I like music and opera and all other kind of culture like theater. So I do manage to do all of those. The most time consuming is really collecting art and collecting antiques, but that's a lot of fun since I've been traveling to so many countries. You know, I spend several hours in each country to just kind of see what can be collected.
And that's one of the things that I really love about you too, Edna, is that, when you and I are together and we've been together in Denmark and Sweden, you love going on the boat cruise and you love going on the opera and you love going to the theater and you love all of these things. And it's just like, it's just so amazing to hang out with you because you are so enthusiastic about experiencing life, really.
Yeah, but at the same time, um, there were many periods, and sometimes now, but less, that I was working every day, including weekends. I mean, I didn't work as much, but for a while, I was a long while. I was working about 70 hours a week,
Yeah.
and then in between doing other things. I tell people, I mean, when they ask me, and especially the young women, what is the secret? I said, first of all, working hard. There is nobody that can reach uh, um, prominence or recognition. It's nicer to say recognition. It's less pompous, and you don't do it without a tremendous amount of work. And then you do have to have some talent as well.
Hard work and talent, I think that, and also your like your dedication. So I've seen you teach many times. You are so passionate about the things that you're talking about. So would you mind telling people about prolonged exposure? What could you tell us a little bit about what is that?
Well, first of all, maybe I would like to start with a little bit of history. Uh, the post traumatic stress disorder was entered into the DSM, which is the book, the sacred book of psychiatry, and all the problems, issues, disorders. And PTSD entered only in 1980. And beforehand, uh, PTSD was mentioned not in the name of post-traumatic stress disorder, but in all kind of names, um, like um, combat combat issues, and mostly really for a long time it focused the research, the literature was focused on combat problems, on uh, people, mostly men, obviously, who were in combat and then had problems like
All right. Let's get you back
so
in
I
here.
hope so. Yeah, we got back. Oh, I made it
You
because
made
I'm
it.
so bad in technology, but I made it. And um, so because of the Vietnam War and all the people that came from Vietnam and showed symptoms like nightmares, like intrusive thought, that interfered with their life tremendously, and that they went on and on and on. It wasn't that it would be just a small. For some people, it was just kind of a several months, but for some people, it was forever. And that really brought the idea that there is here a disorder, if you wish, that is called post-traumatic stress disorder. But we didn't know, and that, because it was post-traumatic stress disorder, it included not only people who suffered from being in combat, but also assault victims, accidents. And so it's kind of put together many traumas and in, uh, in a sequela of the symptoms and the syndrome that we now call PTSD since 1980. So it was really very helpful on the one hand that it kind of put together the symptoms of rape victims and symptoms of combat victims. And then, once you know how to treat one problems, then you can treat the other problems as well because there is a commonality. But we didn't know how to treat any of that. We had a disorder and we didn't have treatments. We had treatments, from World War II, psychoanalysis and hypnotherapy, and it mostly focused on combat related, um, and but there is no research. We didn't know if it works or doesn't work, and so that was an open field. And then I thought, well, it's time for us to kind of create an evidence-based treatment that will work for post-traumatic stress disorder. And that was, yeah, in 1980, I asked, I asked for a grant from the American government to start experimenting with this treatment and with what we call prolonged exposure now. And I also remember that I was working with anxiety disorders before, and I remember that we did have assault victims, rape victims, and also veterans that came up with the symptoms, and for a long term, sometimes 30 years. And I knew that I was doing sometimes some kind of exposure, uh, and that sometimes it worked with them. Uh, so the beginning was, yeah, I mean, it is an anxiety disorder, or it was. I mean, it changed now, but I don't think that it was wise to change it. And anyway, it changed in anxiety related disorder. But we had the basics. Well, at least I thought we had the basics. And then the idea was, is it like simple phobia? Is it like panic disorder? I mean, can you just adjust those treatments to PTSD? And I tried, and it felt that it is different. And the difference was that a, a, focus in PTSD is on the images, and the fact that on the memories, the horrible memories, the traumatic memories that don't go away. And so, in other anxiety disorders, you actually focus on the avoidance. You focus on, where people go, where they're afraid to go. If you are um, a, a phobic of dogs, you don't go near dogs. So you have to learn to expose yourself in contact with dogs to find out that most dogs are safe, and you don't have to be afraid of them. But here we have two problems. One was the avoidance. One was that people did not go to places that remind them of the trauma, and that were so fearful and distressing that they didn't want to connect them. But there was this other idea and problem that they didn't want to think about it either. And the thoughts were, intruding in their mind, and they couldn't get rid of them, and they worked very hard to distract themselves. And then maybe the distraction was failing for a few minutes or for a few hours, but then it came back and it haunted them. So I thought, well, we need to focus on that as well. And that's how a prolonged exposure came about. That it focuses both on um, teaching people how not to be afraid of their memories. That thinking about the trauma is not like being in the trauma. It's thinking about something that was in the past, and thinking is not dangerous. Being in the trauma is dangerous, but thinking about it is not dangerous. So we developed what we called imaginal exposure, or we call it like inviting the patients to invite, deliberately invite the images and thoughts uh, related to the trauma, that they are so afraid that if they think about it, they will fall apart, they will go crazy, and teach them that they are strong enough to be able to tolerate those thoughts, even for an hour, for a long time. And then we also, as homework, we gave them a list of situations that they avoided because they were reminded them of the trauma or they were similar to the trauma. So, like somebody who came back from Afghanistan was avoiding highways in Pennsylvania because in Afghanistan can be dangerous to drive on highways. But in Pennsylvania, the probability is that somebody will throw a bomb on you in the middle of you driving is very, very low or close to nothing, right? So then we have those two methods that we put together. We called it prolonged exposure because we thought that you really have to stay with the memory for very long time until your fear goes down, during the session. We learned later on, quite later on, that you really do not have to habituate or to, see a reduction during the sessions, the therapeutic session, but really, what's important is that you would see reductions between the sessions. That is to say that the peak of the anxiety becomes less and less, over sessions. So now, actually, only recently, and we have not published it yet, but we sent it for a journal a week and a half ago, that you don't have to imagine the traumatic memory for 60 minutes, as we thought. The 20 minutes is enough. And we compared to 20 minutes to 40 minutes, and that it was comparing 1 hour per session in every session to 90 minutes every session. And we find that there was absolutely no difference in in the effect of 1 hour versus 90 minutes. So I wouldn't call it prolonged exposure anymore now, but I can't change the name because once you have a name, it's stuck with you, and it's still prolonged exposure. But I would call it something else now. I would actually call it emotional processing therapy, because what we process is the emotions. We in PTSD, the main emotions. I mean, we have a lot of emotions that are related to it. Fear is one of them, but it's not the only one. Shame is another one, and guilt is another one, and then anger is another one. And stay away from people. I mean, just, kind of getting yourself inside yourself and not relating to the world around you like you used to is another one. So, we in prolonged exposure, which we call PE in short, is really dealing with all these emotions. And we can, because after we do the imaginary exposure or the calling the memory to come on and we stay with it for 20 minutes, then we tell the patient to open their eyes, because we prefer that people would have closed eyes when they imagine, so they can focus more, on their feeling and emotions and what happened. And we said, open your eyes and now tell me, what did you learn? And then we have 15 minutes of what we call processing. And and then we really focus on the emotions that are disturbing the patient. And it can be guilt, And it can be fear and it can be all of them. Okay? So, and we also found in research that changing in the negative cognitions, negative thoughts that that PTSD patients have, like I'm worthless, and the world is in, utterly dangerous, are what keeps the PTSD intact. And so we need to, in the treatment is focusing on those cognitions directly and indirectly. And we found that the reduction of those negative cognitions or negative views about themselves and the world are preceding, are coming before the reduction in PTSD symptoms. So we learned that those are very, very important. So that's kind of in general what prolonged exposure is. And as I said, I wish I could, go all, the way from the beginning and call it what it is, which is really emotional processing theory, therapy.
And it works.
And it works. Well, it works really well. I mean, sometimes I'm surprised how well it works. You see, you have patients that are so difficult. And right now that we finished this study on comparing the 60 minutes sessions to the 90-minute sessions, we did it in the army. And so our patients were all, army, they were all soldiers. And they really had difficult, and they were years and years. And some patients were telling a patient was telling me, I asked him, what's the trauma that haunts you the most? Because in prolonged exposure, we actually focus on the trauma that haunts you the most. Because if you can get over that trauma, then you kind of said, well, the less important traumas I can deal with. But if you start with a trauma that is not so difficult, then you ask yourself, well, I could do that, but could I do the most difficult one? So we start with the most difficult one, I would say with 95% of people, right? And it can be difficult, and it is difficult for about 3 sessions. So 3 weeks. And we see after the 3 weeks, we see starting reduction in the emotions, in the negative emotions. So it's, people think, oh, it's terrible, it's so difficult. Well, it's difficult for a short period of time, but the results among those patients, I mean, among those people that participated, and we had 160 people that participated, so it's a big study. A lot of them, after 8 sessions, were fine, and the treatment itself is between 8 and 15 sessions. Obviously, some people, can go up to 20 sessions if the trauma was so difficult. It happens, but the majority, the average is 10 sessions. And I was surprised how many after 8 sessions were feeling good. So it's important, really, to have a treatment that works well. About 80% of patients that go through PE are doing much better. 20%, for several more reasons than one, are not doing so well. They may be even doing a little bit better, but not good enough for me
Mhm.
to say that they are successful. And 40% are saying, well, I really don't have PTSD anymore. I'm not, I'm fine, which doesn't happen in obsessive compulsive. They get better with exposure, but very few would say, I forgot that I had OCD. But in PTSD, you can get a large number that says, I'm over, it's over. I'm fine now. Um,
And I find it to be so, like what you're saying about how well it works. For me, this has been so important. One of the things that I love about your trainings is that it's so specific. You will teach therapists to give the rationale for both kinds of exposure and then how to actually do the exposure. And one of the things that I found so helpful was like for the first few times I did um, uh, that I worked with PTSD, I was so afraid. I was so afraid of the trauma, and I was so afraid of everything. And so I really leaned on the data and then that this model works because it can be. I'm not saying that it's worse for therapists than for the clients, patients, obviously, and it can be so difficult to keep exposing the client to the traumatic emotions and thoughts. And so leaning on the model and that it works has been very helpful for me and for many of the people that I see and supervise.
but I sometimes think that the therapists are more afraid
Exactly.
of the treatment than the patients are.
Yes.
But when we explain to patients, when we say, look, if you if you broke your leg and you go to the orthopedist and orthopedist says, well, this is not a very good break. First of all, I want to do a surgery to align your bones, and then I'm going to put a cast. But it's going to be more painful and it will take longer time to heal than if I only put a cast and not do the surgery. But if I don't do the surgery, you may, limp for all your life. If I do the surgery, you will. The probability is that you're going to just be fine. That happened to me personally, and so that's why I use it as an example for patients. And I said, "What would you choose?" to the patient, and of course they will choose surgery, that more difficult on the short run, but better on the long run. And after the surgery, then you have to do physiotherapy, and that's painful. And people understand that there are situations, and chemotherapy is not fun, right? And but people understand that in physical situations, you may have to tolerate a pain and discomfort and distress for a short period in order to gain in the long period. In psychotherapy, people don't want to suffer. And, I mean, yes, I said, well, I rather avoid than suffer. And that was not in the times of Freud, for example, because Freud, when he had the idea that the patient has suppressed negative memories, and he wants to bring them up to the cognitions, to the awareness of the patient, he knew it would be painful. I mean, it is painful. If it wasn't painful, they wouldn't suppress those emotions and memories. And it was clear at Freud's time that pain is necessary, or some pain is necessary to recover. I think that the idea that we should not submit patients to emotional pain, it comes, I think, from Um, it comes from um, counseling, from supportive therapy, where the therapist thinks that their task is to prevent the patient from having pain in all cost, and then um, they encourage avoidance, um, and then the patient remains with PTSD for and many times forever.
Yeah. And that is one of the things that I find, so important that you have taught me um, to take this, like as a therapist, we take the stance that the patient can handle this. Like as you said, this is P is not a treatment for trauma; it's a treatment for PTSD, and that the patients, they can handle the thoughts and feelings that shows up. The trauma is might be dangerous. The thoughts and feelings in and of itself are not, right?
And that not dangerous in the sense that you're not going to fall apart,
Hmm.
you're not going to go crazy, and, and that's what people are afraid of. They're not, they're like panic disorder people are afraid if they have panic, they can die,
Yeah.
right, and of heart attack. PTSD patients don't are not afraid that they will die. They're afraid that they will suffer so much that they would kind of lose control over their being. And we teach them that they can spend time again and again, not one time, but again and again, right? Thinking about the trauma and describing it in loud voice. So they actually hear themselves telling about what they see, what they feel. And also, what we do, and we tape tape their discourse, and we ask them to listen to it at home as well. So they don't only listen to it in the session, in the therapeutic session, but also in between sessions. And that's really very helpful because they kind of it gives them the freedom to listen to it and say, well, I feel guilty because I was raped. And, and I feel, ashamed because I let him or her rape me. And then as they listen to, how afraid they were and how they penetrated was so mean. And so um, after a while, they said, it's not my, I shouldn't feel guilty. He should feel guilty, not me. Right? It's clear to me that the situation, he had a gun. If I wouldn't do what he wants me to do, I would die. When I was actually clever and to do what he wanted me to do and stay alive.
There's some beautiful perspective taking work there, like seeing yourself from the outside and listening to yourself. And one of the things that I've noticed in your trainings, Edna, is that you're not only interested in that people tell or revisit the thoughts and feelings and memories. You're so particular about the way that they do it. You're talking a lot about both over engagers and under engagers because you want people to engage in a particular way, right?
That teaching, you know it so well that you can be the teacher. I can interview you.
I
Yeah,
think I've had
because
40 days of PE training by now.
so it's true that we do know, yeah, both from experiment and studies with human beings and with animals too, that if you don't feel anything, let's say that you take a mouse, and you expose them to something that they are very afraid of, but that you kind of give them medication, or so they don't feel anything. Well, then we learn that the fear doesn't extinguish. They have to feel. I mean, their emotions in order to extinguish, in order for the fear to go down, and then eventually not to be afraid. And it's the same with human being.
Hmm.
So you have to have the memory in a place in your brain where you actually are in touch emotionally and in all other ways with the memory. If the memory is in long term place in your brain, it's not going to change. It's going to change only if you bring it to the front of your brain, and then they do feel it, they are in touch with it, and then gradually they learn all the things that we are teaching them. You're strong. It's not dangerous to think about the memory. All of these things, and I'm a strong person. I can do it. All of these things they learn only if they're engaged. So that's why I said that under engagement is not helpful.
Hmm.
Over engagement is the people that really kind of fall apart.
Yeah.
And we have very few of them, maybe 2%, because PTSD patients are very careful and they take care of themselves. So they don't open themselves, they're kind of staying a little behind, and you really have to help them push themselves to take the chance of really open themselves up. So we see more under engagers than over engagers, but we all are afraid of the over engagers. We all are afraid of the people that will fall apart in front of our eyes. And what do we do with them? Um, and because over engagement is not good, because we want to teach the patient that they are in control over their memory and over their emotions. And if they are over engaged, they feel not in control. So it doesn't serve the purpose of the treatment. And so if somebody is overengaged, we change we change some of the way we treat them. Eyes open, not closed, telling it in past tense instead, and kind of making them, maybe writing it in the beginning, what happened, to create a space between the memory and between themselves, so that they realize that remembering is not being in the drama. When they are over engaged, they feel that they are in the drama,
Yeah.
right? And so but in between, you have a lot of space in between. You know, you don't have, there is no one space in which, in which you say, this is perfect. I mean, you could uh, be somewhat engaged or very much engaged, and you will do well,
Hmm.
as long as you don't under engage and not over engage.
Yeah. So words that I often use when talking about this is like flexibility to, flexible, engaging in it. And I love what you're saying about like creating a space between you, like you are the one experiencing your memory. You are not your memory. There's a difference between that. And I love the perspective taking in this. I think that what one of the things that I love about your trainings is that you will show videos. You will actually show videos of patients, so that therapists can see how it's done. And I know you're doing a lot of plays as well. And I don't think I have ever cried as much as during all of these videos. They're just it's heartbreaking, and you will show some of the moments where there's a shift. And one particular video just went straight to my heart, where there's a person, I think, seeing for the first time that it's not her fault. Yeah.
Yeah, yeah. I think that the videos in the role plays are very helpful, and that's why we do 4 day
Yeah.
workshop, because 4 day is a long time, and we could do it in 2 days if we don't show videos, just talk. If we don't do role plays, so the patient can learn about PE and what's PE, and also the theory behind PE as we are discussing. They can learn it in 2 days, maybe in 1 day, but to be able after the 4 days to be in a to have the experience that they can actually know how to do this, not just know about PE, but know how to deliver PE. And many of the patients and of the participants do start to do it by themselves.
They do. And so it generalizes. I've noticed that as well. Like like what they are taught in therapy generalizes. And I see that when the therapist who's been so, between you and me, we've had so many people in Sweden. Not I'm not the only one organizing it, but sometimes, well, there's a lot of skilled people all over the world, and there's a lot of skilled Swedish people doing PE. What I was saying is that we've had a lot of therapists doing this training, and what we see is that they come in, they don't know so much, and they go out like knowing where to start. And then, of course, they start practicing and get better and better and better. But what I love about this workshop is that you will know how to do PE after 4 days. Of course, you need to train and get more experience, but you'll know how to do it. And I love that about your training.
Well, I mean, but this is really the idea. I mean that there are so many workshops in the world about so many treatments in which there are 1 day and 2 days, and then people say, "Well, I learned a lot," and they go back to their practices and they don't use it.
Yes.
And the idea is that we really want to disseminate it so that what we are teaching will actually help their patients.
Exactly. And so I just wanted to check here if there are any questions for. I see that Helen wrote a question for you, Dr. Foa, but you actually answered it as you were talking. So we answered that question. So if you have any questions, so there's one writing here. Oh, that's a question about how to prepare for your workshop, and how to prepare for your workshop. First, you got to sign up. There's a workshop with Dr. Foa on February 14th, 15th, 16th, and 17th. Dr. Foa and Dr. Capaldi will be doing it on Zoom, so you can sit in the comfort and safety of your own home, and it's very cozy. We've done it before. Like we have a cup of tea, and we take breaks, and there's a lot of practical training. And one of the things that you're very generous with, Edna, is materials. Like you'll give out all these forms and manuscripts and materials, and there's a book, there's a therapist manual, and a patient workbook as well. So there are many ways to prepare for this. Yes.
And the Swedish, and it's translated to Sweden. I think it was translated, quite immediately after the first or the second workshop. That some people were very enthusiastic about it. and start to translate. I mean, they got permission, of course, from uh, Oxford University Press. We have a second edition now, but I think that the second edition there are more details, and but the first edition is good enough. If people want to know more, they can. But the second edition, I don't think was translated.
Yeah. So it's the second edition. I think the second edition of your 2000, the 2019 second edition is, I think, is translated into Swedish. I'm pretty sure about that, that it has been translated into Swedish. And so there's a question for you.
How
Uh,
many
there's a question.
languages?
Yeah, there. I think it's been translated into many languages. I know the Swedish
Yeah.
because that's where I am right now. There's somebody asking you, Dr. Foa. Let's see. Let me just see who it is. Um, Olena Erickson asks, depressed patients after PTSD, can they do PE? Depressed patients after PTSD, can they go PE?
Well, I think that what it meant, if people get depressed after the trauma and they also have PTSD, can they do PE?
It
Is
might be
this
so. So so let's see if that this person. All right,
agree?
that's as much as we know.
No, no, no. Um, well, it's one thing that it's important to remember that very few people who have PTSD as their major disorder do not have comorbidity. Many people are also depressed. Some also have OCD. Some also have panic disorder. So you rarely see a patient who has PTSD completely clean without any other comorbidities. So of course, that means that PE has to handle you know, patients with comorbidities. And we did studies on this, and we did analysis of the data that we have. And what we find is that people that have depression are doing as well as people who don't have depression. The only thing is that if you have a patient with uh, very severe depression who stays in bed and doesn't get out of bed and is just, then I think you need to work on the depression first, and then, but that's very rare.
Hmm.
uh, and also, you know, the people that are angry, very angry people, are also a benefit from PE, and we see reduction in the PTSD, but also reduction in anger, and guilt and shame. So, and personality disorders. People with personality disorders are doing well. They're difficult to treat because of the personality disorder. They can be difficult, but when they are treated and they stay in the treatment, they are doing as well with the PTSD, and moreover, people who cut themselves, right, are also cutting much less after after PE than before PE, and even schizophrenics. We have a study from Holland with quite a lot of over 100 patients that they're all on medication. It's schizophrenic and bipolar. They are all on medication. They all have a psychiatrist, but they also have PTSD, and they received PE just as not modified, just PE, For 8 sessions, I wouldn't give them 8 sessions. I would give them 12 or 13 sessions just because, 15, just because they're psychotic. But I think that probably the government of the government in Holland didn't have enough money, and so they had 8 sessions, and the PTSD went down much more than you know, even if they had um, delusion and hallucinations, despite the fact that they also are on medication. So now we know that we can treat. I didn't dare to treat psychotic patient with PE, but now I do. Okay? So the research has shown us that most of the comorbidities um, we can be managed with PE. It doesn't always mean I don't think that PE reduces the psychosis, but it does reduce PTSD in psychotic patients.
And so let's do a final question for you, Edna. There's one here asking, what are important questions for future research in your opinion?
Well, at this point, there are two ways in which we are going with research. One is that we want to reduce the number of sessions. There are so many people with PTSD in the world that we would like to have a minimal number of questions. So we are now doing a study in which we are given a medication, estrogen, that we know that it facilitates extinction of fear. And we are now giving PE in combination with estrogen. And of course, one group will get placebo and one group will get estrogen. But we want to see if we can reduce the number of sessions uh, to a minimum. The other thing that we did was, the 60 versus 90. We wanted to reduce the length of the sessions. We also are interested in how PE works and what changes are in the brain. And so the study we're doing now, we actually are having people under fMRI, and we look at the brain changes before and after PE. So that's kind of where we're going with it.
All right.
But yeah.
So I am aware of the time, and I just wanted to again thank you for so generously spending time with us here. I know you are one busy woman and and scientist and professor and all of that. You are so busy, and the fact that you are choosing to stay here with us is just it's I'm so honored. And so I wanted to finish off by telling people or inviting people to come to the workshop if you want. There are still seats left. It's in February 14, 15, 16, 17. I'll put a link again in the comments here. I'll put a link to the workshop. Come and join us. I can guarantee you will learn a lot. And Edna Foa. So in a minute, I'm gonna log off. So we're offline. I'm gonna ask you to stay on here so that you and I can close the bar together. Before we go, I just wanted to thank you for the difference that you're making in this world by the work that you're doing, both for the patients whose lives you are changing and for all of the practitioners out there, all the things that we're learning from you. And personally, how much I adore you, and I am just so happy that to have you as my friend, really.
Well, it's the same here, and I'm honored that you asked me to be on this cocktail party.
It's
That
always a pleasure hanging out with you.
yeah, the same here.
All right.
And I hope that the participants learned and enjoyed the hour with us, with the two of us.
I hope so too, and I hope, guys, that you see that there's so much to learn from Dr. Foa, and there's so much to learn, and that the learning experience in and of itself. You're a strong woman, and you're so genuine and warm, and very generous with your wisdom and with your materials. I love that. So everybody, make sure to send the love for Dr. Foa in the comments. I will make sure that Dr. Foa gets to see all of the love that you're putting in the comments so that it feels rewarding in that way too. And from the both of us to all of you, we wish you a kind and gentle evening and take care, everybody. Bye.
And Happy New Year.
Merry Christmas and Happy New Year. Yeah. Bye, guys.
Bye bye.